Good morning, good afternoon from where you're joining us from. My name is Aisha Khan, and on behalf of the Canadian Association of Community Health Centres, I want to warmly welcome you to today's webinar. We're so glad to have you join us, and we look forward to spending this time together in conversation and learning. We have a very engaging session planned and an opportunity for you to ask questions and participate in the discussion after the presentations. Before we get started, it's important to take a moment to acknowledge the land that we're on and recognizing the Indigenous voices who have stewarded and cared for these lands since time immemorial is a meaningful part of our work and commitment to truth and reconciliation. So with respect and gratitude, the Canadian Association of Community Health Centres acknowledges that our work takes place on the traditional and sacred Indigenous lands across Turtle Island. CACHC's office is located on the ancestral territories of many nations, including the Mississaugas of the Credit First Nation, the Anishinaabeg, the Chippewa, the Haudenosaunee, the Wendat peoples, and is covered by Treaty 13, signed with the Mississaugas of the Credit, and the Williams Treaty, signed with multiple Mississaugas and Chippewa bands. So just a few quick housekeeping items before we begin. We do encourage you to introduce yourself in the chat box. Feel free to share your name, where you're joining us from, and your organization. And if you have any questions for our speakers, please enter them into the Q&A box. We'll keep an eye on that, and we will get to as many questions as we can during the discussion period at the end. Today's webinar will also be recorded, and a link to that recording and related resources will be shared with all registrants after the webinar. Attendees today are also muted during the session, and if you experience any technical issues, please send a message in the chat and our team will assist you. So here is just a quick look at what you can expect during today's session. We'll begin with a keynote presentation to provide some context on the current state of measles in Canada. Then we'll hear from a series of spotlight speakers who will share frontline experiences and practical strategies and the role of community health centers are playing in response to the outbreaks and engaging diverse communities around vaccination. Finally, before we wrap up, we'll move into a discussion and a Q&A period where we'll address your questions to our panelists. But before we move into our main presentations, I'd like to take a moment to highlight the work of the Community Vaccination Promotion National Project, which is behind today's session. This project was launched by CACHC in 2021 in response to the growing challenges around vaccine hesitancy, the growing misinformation and inequitable access that were intensified by COVID-19, especially among equity-deserving populations across Canada. From the start, this project has been focused on building vaccine confidence, promoting evidence-based information, and helping CHCs address barriers linked to language, culture, and trust. What you're seeing on the screen now is a snapshot of our project webpage, where we've gathered the full scope of our work to date. In this current phase of the project, we're focused on curating, adapting, translating, and sharing culturally and linguistically accessible resources that support equity-informed vaccine promotion for both routine and seasonal immunizations. Everything you see here is available to explore and download at your convenience, and we invite you to share these resources with your teams and communities. We are continuing to adapt resources to address the vaccine information gaps and needs of diverse equity-deserving populations across the country. And now I'm very pleased to introduce our keynote speaker. Dr. Shelley Bulletin is the director of the Center of Vaccine Preventable Diseases and an associate professor at the Dal Honest School of Public Health and the Department of Laboratory Medicine and Pathobiology at the University of Toronto. She's also a scientist at Public Health Ontario. Shelley leads a multidisciplinary research program aimed at evaluating whether our population is adequately protected from infectious diseases. Focusing on population immunity and vaccine effectiveness, this work aims to determine our future risk for outbreaks or epidemics. Shelley has a particular interest in measles control and elimination and has worked nationally as well as internationally in this area. In addition to working in academia, Dr. Bulletin has worked in public health at the provincial and national levels, focusing on infectious disease surveillance and public health emergency response. Please join me in welcoming Dr. Bulletin.
Thank you, Aisha, and thank you so much for having me today. It's really cool to follow the chat and see where everyone is joining from. So I'm going to be speaking for about 15 to 20 minutes to start us off. I'd like to start with the disclosure slide. Thank you. I'm a member of a few Canadian advisory committees related to immunization and public health. you have not advised or consulted for private entities. The Center for Vaccine Preventable Diseases, which I direct, is supported by several funding sources, including vaccine manufacturers. University of Toronto has a very robust set of governance processes to ensure that we are independent. Okay. So we're going to go through first, just a couple of slides on what measles looks like and what the dangers are of measles. Then we're going to talk about the current measles situation in Canada and how we got here. Moving on to which population groups may be susceptible to measles. And then a couple of scenarios at the end that you may or may not be seeing in your practice. So just a couple of slides about measles in general. So the classic measles symptoms are fever, rash, and what we call the 3 Cs: cough, coryza, and conjunctivitis. After about 10 days from being exposed, the infection starts with a prodrome, fever, malaise, just feeling generally miserable, sometimes also with Koplik spots inside of the mouth, but sometimes not. And then about 14 days after infection, or 3 or 4, or even up to 7 days after the prodrome, there's a rash that breaks out. It starts on the face and it advances to the rest of the body. The infectious period is from 4 days before until 4 days after the rash onset. And this is part of the reason that measles is so hard to control, because individuals could be spreading infection before the rash and before that they know that they have measles. Measles is one of the most infectious diseases. It is spread by air, it's spread by respiratory droplets, or even if people touch fomites, like objects that have virus on them. And the virus can stay in the air up to 2 hours after someone who's infected leaves the room. Okay. Measles is a systemic infection, and so that means that it affects most of our organ systems, and that also means that there are a lot of complications. So around 1 in 5 or 20% of individuals will be hospitalized. Young children, so younger than 5, adults older than 20, pregnant individuals are all at higher risk of being infected. Things like ear infections, pneumonia, and diarrhea occur in about 10% of cases. Individuals can have a complication of encephalitis that happens in about 0.1 or 1 in 1,000 cases. And we say that the case fatality rate is somewhere between 1 in 1,000 and 1 in 10,000, depends on the setting and who the population is that's affected. So this is not strictly a complication, but absolutely everyone who gets measles gets something called immune amnesia. So the one of the organs or one of the systems that measles infects is the immune system, and it essentially depletes all of our immune cells. And for the next several years after someone is infected, they're at much higher risk of other bacterial and viral infections because they have lost that immunity when their cells were infected with measles. And that's something that's really, really important to remember. It's not just the acute infection, but the effect can go on for years after. Next slide. Okay, so moving on to what we are seeing right now in Canada. This is a map of Canada from a great resource from Public Health Agency that has a weekly update of the measles situation throughout the country. We have nearly 3,000 cases up until the end of May. The majority of these are related to an outbreak that began in New Brunswick in October and has since spread to 9 jurisdictions, so 8 provinces and 1 territory. The vast majority of cases are children, and really, like almost all of them are either unvaccinated or have unknown vaccine status. Of this outbreak, 85% are confirmed unvaccinated. Historically not vaccinated. 8% in this outbreak are hospitalized, and sadly, we had 1 death a few weeks ago in Ontario. And the vast majority, 93%, have been exposed in Canada. So what that means is right now measles is being transmitted endemically within Canada. Next slide. And so that brings us to why this is such a big deal that it's happening. The fact that measles is circulating endemically is significant because we eliminated measles in 1998, and elimination is a WHO term, a World Health Organization term. It's a technical term, and it is defined as the absence of endemic measles circulation in a jurisdiction for at least 1 year. So we have met those criteria since 1998. Our current outbreak started last October, October 2024, and we have 5 more months to get it under control before we may lose our elimination status because it'll be 1 year of the virus circulating in our country. Okay, so why is this happening? This is WHO data, World Health Organization data, that on the x-axis shows time and on the y-axis shows the number of cases. And we see that post-COVID-19, there was a huge resurgence of measles. So as the world opened up, we see that we have more and more cases of measles. The data are a little bit delayed. So surely the latter half of 2024 and 2025 have a lot more cases than you see right now. So there's measles all around the world. And Aisha, if you can click again. In the words of the Measles and Rubella Partnership, measles anywhere is measles everywhere. I think this is probably not a new concept to everyone that infectious diseases spread very, very quickly around the world because we're all so connected. Next slide. So in order to maintain measles elimination, we say that we need coverage of 2 doses of measles vaccine at 95% of the population. It is very, very infectious, so you need to get almost everybody protected to keep it at bay. The measles vaccine is very effective. 1 dose is 93. 2 doses are 97% effective. The second dose isn't really a booster. It's really just to get us past that 93 above the 95, just to make sure we catch anybody who didn't respond the first time. And immunity is lifelong in the vast majority of cases. So we have a great vaccine. It is very safe. It is very effective, and immunity is nearly lifelong. And so what is happening here? It's very, very hard to capture 95% of any population and to get them vaccinated. We also have vaccine hesitancy, as I'm sure many of you experience. There are a lot of people who aren't hesitant but fell behind with their vaccinations and other health things during the pandemic. And then we also have a lot of people in Canada that have difficulty accessing healthcare. So those are some of the barriers above and beyond how difficult it is to capture 95% of any population. This is exemplified on the right, looking at Ontario measles vaccine coverage as of October 2024. And if we focus on the dark blue line, this is coverage for 7-year-olds. And we see that dip during the pandemic, and we're still recovering from that dip. We're still hoping to get our coverage back up, working on it. But we also see that in 7-year-olds, even before the pandemic, we are not hitting 95. Next slide. Thank you. Okay. So we started our vaccination program in Canada in the early 70s with 1 dose. In 1996, throughout Canada, we added a 2nd dose of vaccine. And throughout the country, we administer the first dose at 12 months of age. And the timing of the 2nd dose varies. It could be either 18 months or 4 to 6 years, depending on the province or territory. And the formulation can also vary. It can be given as a MMR, so measles, mumps, rubella, or as MMRV, measles, mumps, rubella, varicella, again, depending on the jurisdiction. However, during this really unprecedented outbreak, we haven't seen something like this in a few decades, there are regions where the public health authorities decided to accelerate the schedule. And so that is in Southwest Ontario, as we see in the map on the top right, and I believe also in Northern Alberta. I'm in Ontario, so I'm showing the Ontario schedule where we see the routine schedule compared to the outbreak schedule. And the point of the outbreak schedule is to get everybody fully vaccinated as soon as possible. So we're accelerating the first dose in infants, and we're also accelerating the 2nd dose, so giving it as soon as it is appropriate to do so. In adults, we'd like to make sure that everyone in the outbreak area has 2 doses of vaccine. Next slide. Okay. So moving on to which are the groups who may be more likely to be susceptible to measles. So first and foremost, of course, unvaccinated individuals. And there are a lot of reasons why people may not be vaccinated. They could have philosophical or religious reasons that prevent them from being vaccinated. As I mentioned earlier, they could not be hesitant, but experience delays to various aspects of their lives during COVID. They could be immunocompromised. So measles, mumps, rubella, and measles, mumps, rubella, varicella, they're live vaccines, and they're contraindicated for the vast majority of people who are immunocompromised, which is why it's all the more important that the rest of us who can protect ourselves, we're also protecting those people by herd immunity. And the last group is infants too young to be vaccinated because, as mentioned in the last slide, we wait until the age of 12 months to vaccinate individuals. So in the next slide, we are going to focus on that. So here we have measles cases in Ontario for 10 years ending in 2023, and about 13% of the cases before the current outbreak. The current outbreak has a different epidemiology, but historically about 13% have been infants less than a year old. And the classic scenario is an infant is traveling with their parents abroad to an area that has measles. They are too young to have been routinely vaccinated, and they get measles abroad and bring it back. So this is a situation that we want to avoid, and we'll come back to that in a few slides. The next group who may be at risk is some individuals who are born outside of Canada. Of course, this is a very heterogeneous group. We're not going to paint them all in one brush, which is why it's in brackets. But what be happening is that individuals may be coming in from countries that have a different vaccine schedule. They could be coming from places that have a lower vaccine coverage than Canada. And when vaccine coverage is mediocre, there is a scenario where you could have people in the population that are neither infected nor vaccinated, and so they would come and into Canada and be susceptible. And we all also know about difficulties accessing healthcare upon arrival in Canada. This is a huge issue, particularly for equity deserving groups. For example, recent immigrants. On to the next slide. So we endeavored to look at this really from an equity perspective, because in the absence of a vaccine registry, sometimes we look at immunity in order to understand where inequity is lying in our population. On the top right is a picture of Archana Raja. He is my PhD student, and he looked at measles immunity results from the Public Health Ontario labs and compared immunity of people born inside Canada versus born outside of Canada. So here on the x-axis, we have birth year, and note we're looking at people up to age 40. So born from 1985 and later. And on the y-axis, we look at the proportion immune at each group. And we see that for individuals who are 40 or younger, a lower proportion of immigrants are immune compared to Canadian-born immigrants. And of course, the limitation of this is we don't know why. We don't know if it's an access issue or a hesitancy issue. That requires further study, but this was kind of a first asking the question of, is there an issue? And next slide. And the third group is travelers. So especially if you're traveling to areas where measles is endemic, or if you are somewhere where a lot of people are gathering who may be coming from many places, like an airport, for example. Next slide. So once again, looking at Ontario data, this is measles cases in Ontario stratified by whether they were acquired or imported from abroad or not. And we see that the dark blue was imported, and more than half of the cases that we're seeing here were acquired outside Canada. Now, the lighter blue are cases acquired in Canada, but in the majority of the cases with these data, they were acquired from people who had traveled. So they're still kind of indirectly related. And Aisha, if you can click again, thank you. If any of you have seen these types of notices or news articles advising people about measles exposures on airplanes or at airports, I see these. I mean, I look out for them a little bit more than other people, but I see them, every 3 weeks or every month or so. So this is an ongoing issue. Okay, I'm going to end with a few scenarios. And for each scenario, I have written down where the guidance is from. Uh, Measles guidance is generally uniform, but there's a couple of things that differ from source to source. So I thought it would be good to just tell you where this is from. The first scenario is if there is a patient who wants to make sure that they're protected from measles, but they have an unknown vaccination history. This is from the Canadian Immunization Guide. The first thing we'd ask is, was the patient born before 1970? In Canada, and this is uniform with all guidance, if individuals are born before 1970, we feel that we can presume that they're immune because individuals born before 1970 are likely to have been infected in childhood before we had routine vaccine programs. So we can presume that they're immune. However, the Canadian Immunization Guide recommends that if someone is traveling, they should have a dose, even if they're born before 1970, just to be sure. If they're born 1970 or after, we do not feel that we can presume them immune based solely on the year that they were born. And just make sure that there are no contraindications with this live vaccine, and then they should be vaccinated. The Canadian Immunization Guide says that adults should have one dose, but there are various scenarios in which they say that they should have two doses. For example, if you're a healthcare worker, I've also seen federal, provincial, and local guidance that says that even adults should have two doses. So that's why I put that in red as one or more. Individuals may come in asking for a blood test. Of course, while you do whatever you think is appropriate in clinical practice, the public health guidelines generally say that serological testing for the general population is not recommended. And when there's a question of immunity, the more efficient thing to do is to vaccinate. And just to reiterate or to just reassure that there's no safety issue associated with re-immunization. So if this person who has an unknown vaccine history has actually already received two doses and they're given two more, we're not expecting any adverse events above and beyond just what we would usually expect. Okay, scenario two is the traveling infant from a few slides ago. Infants are never considered immune to measles. It is true that infants are most of the time born with maternal antibody that may be protective, but we can't make that assumption. When we vaccinate infants earlier than 12 months, that vaccination is less effective. Firstly, if they have maternal antibody that is circulating, that's going to mop up the live virus, that's the vaccine virus, but they also have an immature immune system, so they just can't make as robust an immune response, and for those reasons, we're waiting until 12 months. However, if someone is traveling to an endemic area, we prefer to have some protection over no protection. And guidance, this is from the CIG, but this is again quite uniform, says that infants who are at least 6 months old can be vaccinated early if they're traveling to areas where measles is a concern. This is the exact recommendation, is also part of the outbreak schedule. So if you're vaccinating a traveling infant at age 6 to 11 months, we call this a dose zero. It's very important to know that they still require the two routine doses and that the first one should still be received 12 months or later as per the routine guides. And the last scenario turns things around. And this is about a case that potentially might be measles and making sure that everyone is protected. There's ample guidance that's very, very helpful from both Public Health Agency and Public Health Ontario on how to do this. First, schedule the patient to minimize exposure to others. So last thing in the day, for example, ensure that the patient is masked and that they're immediately placed in an appropriate room. The guidance says that negative air pressure is preferred, but of course we know that that's not feasible in a lot of cases. So certainly something with the door that is as airtight as possible. That door should remain closed afterwards for about 2 hours with a sign on the door telling people not to come in. There are some facilities that have a faster air exchange where you could probably do it in less than 2 hours. Your infection control would tell you that, but in the absence of those indications, it should be 2 hours. The guidance says that only healthcare workers that are immune to measles, so have either two vaccine doses or lab evidence of immunity, should be carrying for the patient. Public Health Ontario goes further and said they should also wear an N95. The guidance varies on this, but this is what PHO says. It's also what CDC says. Susceptible healthcare workers should not enter a room or, interact with a patient who may have measles. Public health agency says that when this is unavoidable, the individual should wear a respirator. So that is it for me. I just wanted to list some resources that I use all the time that may be helpful. On the left, we have the Canadian Immunization Guide. This is like my go-to website, like my first stop when I need to know something. On the right is the Public Health Ontario website, which has a lot of really helpful information about measles exposures, measles infection control, testing indications, pretty much anything you want to know in depth and with references. Thank you very much for your attention. That's all for me.
Thank you so much, Dr. Bolton, for a very timely and insightful overview. To bring us closer to what this looks like on the ground, I'm excited to introduce our first spotlight speaker, Tariq Abdulhadi. Tariq is a health promoter and team lead at the Woolwich Community Health Center and a member of the IPF team. Working alongside their primary care team and the Mennonite outreach workers, Woolwich Community Health Center has been on the front lines of the measles outbreak among the rural communities in the Waterloo region. Welcome, Tariq.
Hello, everyone. Thank you for being with us today, and thank you for having me. Really appreciate the CHCHC for hosting opportunities like this for us to gather and discuss and share experiences with situations like this. I think it's a great opportunity to showcase and learn from one another. My name is Tariq. I'm the health promoter and team lead at the Woolwich Community Health Center. We are in the rural parts of the region of Waterloo, and I'm here to talk about the importance of relationship building with community health centers and their communities, and how we are reminded of the importance of trust during the ongoing measles outbreak. So I'm going to be mentioning some things that we worked on and that worked for us and didn't work for us with the Mennonite population in our region. Next slide. So just a quick intro to our organization. So the Woolwich Community Health Center is located in rural Waterloo region. We have 3 locations to serve the rural populations of the Waterloo region. And I remember Dr. Shelley just mentioned the negative pressure rooms and how useful those are. We're very privileged to have one of those in our second location. We moved to a brand new building, and we were fortunate to be able to include a negative pressure room at our second location. And when we were doing that, I thought, we're not really going to be using that, but boy, sure, that was, I was wrong about that. That was very timely for us to have that negative pressure room. Yeah, so we have 3 locations in rural Waterloo region, one in St. Jacobs, one in Wellesley, and a small nurse practitioner's office in Linwood. So we do serve the general population, but we also strive to focus on minority groups who may have barriers in accessing primary care, like the farming community, Mennonite communities, which are prevalent in the rural landscape of our region. So yeah, we aim to be a one-stop shop for healthcare. We have a team of doctors, nurse practitioners, nurses, mental health counselors, physiotherapists, dietitians, chiropodists for foot care, dental team. And we also have a community team that does outreach and preventative programs and services from youth all the way up to seniors and much more. Next slide. So, as most of you are aware, and the measles outbreak across Canada is indeed a situation. Um, and as Dr. Shelley mentioned, it is disappointing to be dealing with an outbreak of something that was eradicated in the 90s in Canada. But I'm not surprised with the increase in vaccine hesitancy as a result of many things, but primarily that we've seen after the COVID-19 pandemic. It's no surprise that measles has made such an unprecedented comeback. And I hope we don't lose our status in that we've eradicated or eliminated. So here we have the number of measles cases across the public health units in Ontario. I have highlighted here our region as of this. So this data is as of June 10th. So according to Public Health Ontario, there have been 89 confirmed cases and hundreds of probable cases. We are also very close neighbors. We're just a stone throw away from Huron Perth Health Unit and Southwestern Public Health. and together we have a little more than half of the confirmed measles cases in Ontario. Um, and I just want to say I really like that quote that you mentioned in your presentation that a threat anywhere is a threat everywhere. And this is why we need to take into consideration populations that are typically missed during public health initiatives. And I'm going to talk about that population and our experience with them. Next slide, please. So the Mennonite population. This is a very unique population that we are focusing our immunization project on here in rural Waterloo. So the Waterloo region is home to one of the largest and most diverse Mennonite populations in Canada, including so there's different sects of the Mennonite population. So there's old order, conservative, and more modern Mennonite groups. And many families have lived in the region for generations, with roots going back to the 1800s, when Mennonites migrated from all over the world, including from Russia, parts of Europe, and Mexico, and they came here seeking religious freedom and farmland. Their history is quite interesting. I have been learning about these groups for a handful of years now, and I still learn more about them each year. Today, they continue to maintain a distinct cultural and religious practices, with some more conservative groups avoiding modern technology and preferring plain and traditional clothes and more traditional modes of transportation like horse and buggy, like you see in the photo. If you drive around the northern part of Waterloo, you'll see them on the roadways in horse and buggy. And their strong sense of community, self-reliance, and cautious approach to outside influences, including healthcare and vaccination, means that building trust and respectful relationships over time is essential for effective public health engagement or public health initiatives. And especially the more conservative groups, they want absolutely nothing to do with the outside world, which makes it a little bit tricky, as you can imagine. Next slide, please. Which brings me to my main point in my presentation, which is that trust between community health centers and their communities is the backbone for public health, the success of public health initiatives in rural communities. Well, it can be applied to any community really, but it's really the thing that holds together the projects that you do here. And I put that in quotation to make it look more legitimate. But in the nonprofit world, we all know this. We don't talk in currency, we don't talk in money, we talk in impact, we talk in trust and partnership with our communities. In relationship for service delivery. And I know that might sound cliche, but I can't emphasize how true that is. I'm going to share our experience with the immunization project and our Mennonite communities to drive this message home. Because in all honesty, without community health centers doing the work that we do across the country, there would be countless numbers of groups of people without access to healthcare and other essential programs and services, and might be left out of public health initiatives and projects. But yeah, I'll be completely honest. Our immunization project at the Woolwich Community Health Center would not have been successful if it weren't for decades-long relationship building and with the Mennonite communities. In fact, I would say it would have been extremely difficult, if not a failure, if we didn't have the relationship and trust with these communities. Next slide, please. So before I get to that, I want to go over what experience and education have taught us in a nutshell. So for me personally, I have a Master of Public Health degree from the University of Waterloo, and I worked in the Peel region during the pandemic for public health initiatives around COVID-19 vaccine uptake. So I've done a lot of work around vaccine promotion, education, outreach, awareness, and at the COVID-19 testing center, seeing a lot of grown men cry when we stick something up their nose. So generally for a public health initiative or project, you need to have community engagement. You need to have trusted relationships, culturally appropriate outreach, education and awareness, accessible services, partnerships, evaluation and feedback, and so on and so forth. And when I started working with the Woolwich CHC 3 years ago, and working specifically with the Mennonite population, I quickly learned that much of what I know and much of what I learned does not work with this population. And I'll briefly give you some examples. Next slide, please. Here's my rough notes of what works and doesn't work. So, community engagement. So, advisory group Forget about it. I struggled to put one together, not because I suck at my job, but because Mennonites would view that as a betrayal to their community. I got one Mennonite gentleman interested and got him in for a meeting to introduce him to the project. He was a Mennonite pharmacist, actually, who was well known and trusted in his community, and I thought he was perfect for the role. After the initial meeting, I could tell he was spooked, and he later told me that he has to decline his involvement in the project simply because if his community found out that he was part of the project, or even part of, this outside world kind of government program or whatever they want to call it, they would see it as a betrayal of some sorts. Even though I assured him it would be completely anonymous, he felt guilty and he couldn't do it. Um, so our unofficial advisory group ended up being our Low German interpreter, who I'll get to a little bit later. So when it comes to an outreach team, you can't have an ordinary outreach team because they simply won't engage or trust you if you're a random person from the outside world. We are very fortunate to have our Low German outreach worker, and Low German is the language that some of the Mennonite groups speak. So we're very fortunate to have a Low German outreach worker who has been working with us for many years and helping the Mennonite programs and service delivery. And she is also an interpreter for the Mennonite population's medical appointments when they come in to speak with their primary care provider. She is our lifeline into the community. She has been our bridge in developing trust between the Mennonite communities and our CHC. Um, and culturally appropriate outreach. This was very difficult because most Mennonites don't read English. And I know what you're thinking, just translate it. If you try to translate it into Low German, that's the language that they speak. Most of them don't read that either. So the Mennonites are very oral in their mode of communication. They don't rely on written material. So by default, this makes education and awareness very difficult. Um, and on top of that, most Mennonites pull their kids out of school when they reach the age of 12. So around grade seven or eight. This is when they legally can pull their kids out of school. Once they pull their kids out of school, the kids start working with their families on the farm, woodwork, or what have you. So when we create print materials, we have to use pictures instead of words. When we create videos, it has to be short, simple, and audio based with a very simple animation with little to no medical terminology because many Mennonites don't even know what germs and viruses are. So it can be very challenging to explain how a vaccine works. Um, Also, it has to be a man's voice in the video because Mennonites generally are not receptive to women. Um, and I know what you're thinking. Didn't you just mention that your Low German outreach worker is a female? What did we do? I used AI to turn her voice to sound like a man, and it actually worked out really well. Um, and then some of you might be wondering, well, how can you do a video if some of them don't use technology? The animation videos we created are for the more liberal Mennonite groups, which use some technology more so than the conservative groups. They're big fans of WhatsApp. We have lots of WhatsApp groups with some of the Low German Mennonite communities, so we send out our videos through there. And it's available on YouTube as well. Accessible services, very important. This applies to any population. If they can't come to you, you go to them. This is why in 2003 and 2005, we opened up two satellite locations across the townships. And we also hired buses and also just drivers to bring them to our clinic when needed. Um, Partnership has been challenging because these communities rely heavily on what their church leaders say. And unfortunately, many of the church leaders do not want to have outside world influence in their church. Not to mention, some of them are also anti-vaxxers, which poses a challenge for us. Um, and evaluation and feedback. So we are currently starting this process of our IPF project. So we're currently jumping this hurdle. Um, and what we're starting to realize is that we can't give folks surveys to fill out since they can't read or write in English or Low German. So we have to facilitate these evaluations individually, one-on-one with our outreach worker. So yeah, so working with this population has been the most rewarding and the biggest challenge in my career so far. So everything about my public health practice has been put to the test and has been extremely modified to work with this population. There are so many barriers to anything you do. Like you've got language, literacy, religious beliefs, transportation, lack of education. and a strong view of not interacting with the outside world. But despite the uphill battle and navigating, the language, literacy, cultural norms, and trust, this experience has reshaped the way I approach community health, teaching me that success isn't about following the standard public health playbook. Sometimes you got to get a little creative, but also reminding me about how you have to listen deeply and adapting and building relationships one conversation at a time. Next slide, please. So how did we build trust as an organization over the years? So Mennonites have been one of the priority populations for us for decades. We have been tailoring our primary care to accommodate for the Mennonite population in our programs as well. And we're very proud. I'll give you one example. We're very proud of a program called GFK, which stands for a Low German phrase. It's a pre and postnatal program for Mennonite mothers, and we started that in 1995. So we're just celebrating our anniversary with that this summer. This program has Mennonite outreach workers, nurse practitioner, dietitians, and several other staff that facilitated this program a few times a month. We have staff that have been building relationships with this community for decades to build this trust. So all of this is to say that without decades of trust building between our community and community health centers, we would not have been able to be successful with this project. We have surpassed all of our goals before the end of the first year of our immunization project, and that would not have been possible without these relationships with the community. Even with decades of relationship building with our CHC and this community, we still face challenges and struggles. And in the end, it's not a single program or strategy that earns trust. It's just decades of showing up for the community, advocating for the community, and listening and adapting to their needs and just walking alongside them that makes any meaningful progress possible. Next slide, please. Yeah, I'll finish with this. So in the end, just because our organization is given X amount of dollars to make a difference, they will struggle to make an impact if they haven't been building trust and relationships, showing up and listening and being an advocate for their communities. So relationship building and building trust is where the hard part is. Once you have that, the rest is easy. Thank you so much.
Aisha, you're on mute.
Oh, thank you. Thank you so much, Tarek, for those powerful insights and the trust building strategies that you and your team are putting into action in your community. So our final spotlight speaker today brings another crucial perspective to this conversation. Irene Santos is an internationally trained medical doctor, mother-infant nutrition master, and public health sciences PhD from the University of Guadalajara, with over 25 years of experience caring for disadvantaged populations, teaching, and researching. At Umbrella Multicultural Health Co-op, Irena has ample experience in supporting new immigrants' health and well-being as a cross-cultural health broker, mentor, and program coordinator. Currently coordinating a health promotion program for 4 ethno-cultural communities, Irena is applying her knowledge and skills in developing a wider cross-cultural understanding and communication while training a team of community health workers and cross-cultural health brokers. Welcome, Irena.
Thank you very much. I'm grateful to be here and happy to be here. Well, measles is an old disease, but appearing and reappearing. This is a context already discussed. I just wanted to say that these numbers on your right for each of the provinces and territories are from June 9, and they were updated on June 16. So for BC, where Umbrella Multicultural Health is, the number is not 12 anymore, it's the 30 as of 2 days ago. Well, this is a context was eliminated in Canada in 98, but since then we have had 3 or 4 outbreaks. The previous in 2014 is a little map with the red spots, mostly in the west. And this 2025 starting in the east, but as we can see in the US, started in Texas in Mennonite communities exactly, but spread to all of the states. So the global outbreaks in many countries, the US profoundly affected, and our country starting in the east, but now spreading to all. Can I have the next one, please? Okay. So there were to June 9th, 12 cases. Now we have 30 cases in BC and 18 reported in the Northern Health Authority just this week. So at the beginning were travel related, but then community transmission, right? That's the context, that's where we are living now. Can I have the next one, please? And although we have a very effective vaccine, almost 100% with 2 doses, what we have is a lot of measles activity around the world, and we have low vaccination rates. On the left and below, we can see numbers in the US and how in 2019-20, a sharp decline in the vaccination rates for many diseases, grave diseases, polio, measles, whooping cough. So that means vulnerable populations. That's what it means. And please see the numbers on your right. The Gaines County in Texas, the epicenter of the disease in the US, had 82% of vaccination rate in 2023. Just to say that here in British Columbia, we have 81%, less than them. So we are vulnerable. We are vulnerable. This is the context that we work to build awareness, to build knowledge, to build a change in the behavior and getting the vaccine. How we do that? Can I have the next one, please? At Umbrella Multicultural Health Co-op, a community health center, we have a health promotion program. And this health promotion program is designed to serve 4 ethnocultural communities of newcomers, speaking 4 languages. So we have 1 community health worker speaking from that community, speaking that language. This program has characteristics. It's an open program. Everybody can join. We don't require anything, not even the name of the person. Absolutely nothing. Anybody is welcome. It's guided by the community members. It's very flexible. We do things in person. We do things online. Very flexible, not only in the weekdays, but in the evenings and the weekends. And we go all Metro Vancouver.